Raynaud's phenomenon. In 1862, Maurice Raynaud described RP, which is a vasospastic disorder characterized by episodic attacks of well-demarcated color changes with numbness and pain of the digits on exposure to cold. It may be primary, idiopathic, or secondary to an underlying condition. Primary RP is also called Raynaud's disease. How common is primary RP? Who gets it? The prevalence of primary RP is estimated to be 3% to 5% in most studies. Prevalence is higher in colder climates and among women, younger age groups, and in patients with a family history of the phenomenon. RP commonly develops at a young age. New-onset disease after the age of 60 years is uncommon. Prevalence, 0.1% to 1%. The female-to-male ratio ranges from 4:1 to 9:1. Estradiol increases the expression of alpha-2C adrenoreceptors on smooth muscle cells, leading to increased cutaneous vasoconstriction. This has implications outside of RP, as baseline digital blood flow in young females, but not postmenopausal females, is lower than that in males in the general population. Which conditions are associated with secondary RP? Conditions associated with secondary RP may be grouped into 7 broad categories. 1. Systemic. 2. Traumatic. Injury. 3. Drugs or chemicals. 4. Occlusive arterial disease. 5. Hyperviscosity syndromes. 6. Endocrine disorders. And 7. Miscellaneous causes. From Rheumatology Secret Textbook. Discuss the relevant pathophysiology of RP. In the normal physiologic state, cutaneous blood flow to acral sites such as the fingers, toes, and tips of the nose and ears serve as an important part of the body's mechanism of thermoregulation. Cutaneous blood flow can exceed 6 L per minute in periods of hyperthermia when the body attempts to vent heat through such sites. In contrast, cold environments can drop cutaneous blood flow to nearly undetectable levels. RP represents an exaggerated vascular response to cold and stress, most commonly at acral sites responsible for thermoregulation. Neural signals, circulating hormones and mediators from immunomodulatory and endothelial cells all may affect blood vessel reactivity. Subsequent changes in blood vessel radius play a prominent role in RP, as a given reduction in radius results in a 4-fold decrease in the blood flow, law of Poiseuille. Neural signals that modulate vascular reactivity include epinephrine, norepinephrine, vasopressin, bradykinin, histamine, and leukotrienes among others. Additional mediators from circulating cells include serotonin and ATP, ADP. Mediators from endothelial cells include prostacyclin, nitric oxide, endothelin, and other contractile factors. Patients with RP, therefore, suffer from diminished cutaneous blood flow due to alterations in the neural input, primary and secondary RP, as well as mediators from endothelial and immunomodulatory cells, secondary RP. Compare the pathophysiology of primary RP with secondary RP. Primary RP Individuals without RP exposed to cold experience increased sympathetic adrenergic input, vasoconstriction, to the cutaneous vasculature as well as increased alpha-2C adrenoreceptor sensitivity. Activation of these receptors on vascular smooth muscle cells results in decreased blood flow through the digital arteries and arteriovenous anastomoses. This helps to divert blood flow and guard against excessive cutaneous heat loss. Nutritional blood flow to the skin supplied by capillary loops distal to the arteriovenous anastomoses, however, is not affected. In primary RP, there is increased basal sympathetic adrenergic tone as well as increased alpha-2C adrenoreceptor activity, even at neutral temperatures. In cold environments, this adrenergic input is heightened and affects not only the arteriovenous anastomoses most prominently but also the digital arteries and veins, and less prominently, the nutritional blood flow through the distal capillary loops. Nutritional blood flow in primary RP is diminished, but preserved, due to intact endothelial function. Secondary RP. In patients with secondary RP, underlying vascular disease may disrupt the normal mechanisms responsible for the control of vessel reactivity. Examples include impaired endothelial vasodilatory function, diminished nitric oxide release, and increased generation of factors, such as endothelin or ultra-large von Willebrand factor. Furthermore, patients with systemic sclerosis, SSC, may have evidence of intimal proliferation, an abnormal platelet adhesion to the endothelium, resulting in reduced vessel lumen size. Consequently, blood flow through the distal capillary loops may be severely decreased in secondary RP, resulting in tissue injury. Pearl. Primary RP should not cause digital ulcerations, preserved nutritional blood flow to the skin. The presence of digital ulcerations and/or infarcts should prompt further evaluation for secondary causes of RP. Describe the triphasic color response of RP and briefly explain the pathophysiology of each phase. The sequential color changes of RP are white to blue to red. Initial digital artery vasospasm causes a pallor, blanching, of the digit Fig. 74.1, which gives way to cyanosis as static venous blood deoxygenates. With rewarming, the ischemic phase lasts 15 to 20 minutes followed by reactive hyperemia which causes the final stage. Rubor. The classic triad in the classic order may not be seen in all patients. Pallor is the most definitive phase. Contrast the clinical presentations of primary and secondary RP. The onset of primary RP usually occurs in women aged 15 to 30 years. The fingers are most commonly affected, but 40% of patients have attacks in the toes as well. Ears, nose, tongue, lips, and nipples may also be involved. The thumbs are frequently spared. The well-demarcated color changes involve part or all of one or more digits, never the whole hand. On exposure to cold, the color changes may be accompanied by numbness during the ischemic phase and by a throbbing pain during the reactive hyperemic phase. The frequency, duration, and severity of attacks vary widely, with some patients having several attacks per day and others having 2 or 3 per winter. Primary RP patients do not develop trophic complications such as digital ulceration, pitting, fissuring, or gangrene. NCM examination and serologies are normal, negative. The onset of secondary RP is usually in the 3rd and 4th decades and may be seen in either men or women depending on the underlying condition. The symptoms of digital vasospasm are the same as those of primary RP. However, secondary RP patients are more prone to trophic complications. Signs and symptoms related to an underlying condition may be discovered by a careful history and physical examination. Nail fold capillary microscopy. Examination and serologies can be abnormal depending on the underlying disease. Is cold the only precipitant of RP? Cold exposure is by far the most common precipitating cause of RP, especially when accompanied by pressure. Typical examples would be the gripping of a cold steering wheel, holding a cold soft drink can, or grasping items in the frozen food section of a grocery store. An attack of RP can also occur after stimulation of the sympathetic nervous system, such as with pain and emotional distress. Other potential stimuli include trauma, hormones, medication exposure, and certain chemicals such as those found in cigarette smoke. Additional causes, such as vibration injury, are more correctly attributed to the associated conditions of secondary RP.